Hello, everyone. My name's Solomay Tibabu. I'm the host of Going Digital Behavioral Health Tech. Really excited for our session today. We've got Yusuf and Christine. Before we jump in, perhaps some quick introductions. How about in that order? Yusuf first and then Christine, please.
Thanks, Salome. Great to be here. My name is Yusuf Sherwani, and I'm the CEO and co-founder at Quit Genius. And we are an integrated substance use care program.
Hey, good morning, good afternoon. I'm Christine Shulze, and I am a licensed clinical social worker. I've been in the field of behavioral health for about 25 years and currently work on the behavioral health consulting team at Mercer, where we provide guidance to employers on designing their mental health and substance use benefits.
Excellent. Can't wait to jump in. So without further ado, maybe Yusuf, I'll start with you. Can you just talk about your view on the mental health and addiction space in the past few years? Lots of changes and what would you say the state is of addiction?
Yeah, it's a great question. I think, the last 2 years have been particularly challenging from a behavioral health standpoint. As we look at substance use disorders, actually, sort of 2021 was in many ways the worst year in drug history. And COVID was the straw that broke the camel's back. So sort of substance use disorders that had been on the incline for several years really started to accelerate over the last couple of years. And as we sort of delve a little bit deeper in the opioid crisis and just the rise in alcohol sort of use disorder, what's pretty clear from a lot of the metrics and the graphs that you start to look at over the last couple of years is that we still have yet to peak. So, as an example, for instance, for the for the period ended September 2021, we saw the highest rate of opioid overdose deaths, over 100,000 people who died from opioid sort of overdose, versus what we've seen in prior years. And then even in the first year of the pandemic, actually, we saw a 25% increase in alcohol, related deaths as well. So it's not a pretty picture. Unfortunately, it has been, a real challenge for many people for a number of different reasons. But I would say, like, within all of that, one of the silver linings I've seen is that behavioral health has actually become a national priority. It's the first time it's actually made it earlier this year to the President's State of the Union address. And we've actually started to see us chipping away at some of the stigma associated with certain behavioral health conditions, such as mental health as well. And, it's people now feel a lot more comfortable coming forward when they have a mental health illness and sort of seeking out treatment and not feeling like there is a fear of repercussion. And employers have become a lot more proactive about that as well. My hope is that we can do the same in substance use disorders. We're starting to see a trend in that direction as well, and a recognition that actually it is a chronic condition. It's not a moral failing, but there is still some work that needs to be done in order to really open up access to effective treatment and ensure that people who are going through these challenges on their own, for the most part, actually are able to access and engage in great quality healthcare, and they don't feel like there's any fear of repercussion or sort of stigma or anything else that has otherwise been a barrier to accessing that type of care.
Wow, you mentioned failure. Like, how did we get here? I mean, how did the medical community and beyond just let this happen?
It's a great question, and it's a super, super complex question. So, the answer there is fairly nuanced. So if we look at the opioid crisis on its own, and there hasn't been a month over the last few years that's gone by where you haven't seen some kind of headline related to the opioid epidemic. That is definitely one that's been long in the making and entirely avoidable. So it was an intentional program by a number of pharmaceutical companies in the late 1990s, and sort of really propagated on the false assurances that actually opioid pain relievers wouldn't be addicted. And there was a sort of false stat that was put forward that fewer than 1% of people with an opioid addiction on opioid medication would actually develop an addiction. That was patently not true. And it turns out that both patients and the medical community was deceived, and we just acted incredibly slowly around that. Alcohol is a different sort of challenge altogether, one that is characterized by a lot of stigma when it comes to just accessing high quality providers and breaking down some of the barriers that exist to accessing those sort of types of treatment programs. But I think, like, what's interesting as you sort of look at how we got here is there wasn't a lack of sort of recognition that that prevalence was actually increasing around these conditions, people and the medical community started to understand pretty early on that actually, these are real sort of urgent situations that need to be dealt with in some way, and we need to make sort of treatment available to people. I think as we sort of delve a bit deeper, what actually became a lot more challenging wasn't diagnosing that there is a problem today, and that the prevalence stats are headed in the wrong direction, but actually in making treatment available to people in the first place. So I sort of look at three overall pillars that probably account for the majority of the challenge that we face today. And the first is actually just access to care. So unfortunately, 40 million people with a substance use disorder, 40 million Americans have a substance use disorder today, and that number has only been rising year on year. But only 10% of them actually have access to high quality treatment. And often that's because great providers aren't available in those locations, and there's a lot of stigma in accessing treatment in the first place. But the second one is also care quality, right? So when people actually do have access to treatment, then often they don't have access to high quality treatment in the first place. And substance use disorder treatment is definitely an area of healthcare that's characterized by a bit of a wild west and a lack of adherence to evidence-based practices. So we've known for decades what types of treatments are actually effective for people with an SUD in the first place. And it turns out that it's some combination of medication-assisted treatment, cognitive behavioral therapy, and really understanding the social determinants of health. But actually fewer than 15% of providers, according to independent research, actually follow those evidence-based guidelines. So you have this access problem, and then only 10% of people are getting access. And those people are often getting access to low quality care in the first place. And then the final one, and this is definitely something that's starting to be better understood, is around equity. Because sometimes it's actually the demographics that most need access to care where substance use disorders are accelerating the fastest that have the least access to it in the first place. So, for instance, one of the demographics that has been hard hit by alcohol use disorder, particularly over the last couple of years, is women, and single women in particular. And unfortunately, the current paradigm of going to an inpatient treatment facility or waiting sort of weeks for an appointment and driving across town just doesn't work for that group. And as a result, they don't actually access treatment themselves. So we're starting to see that actually it's the minority groups and the diverse groups that typically are the ones that have the lowest amount of access to healthcare for substance use disorder in the first place. So I think those three pillars definitely explain a lot of the challenges that we face, certainly not all of them. But it's also one where there is an opportunity to potentially actually have more of an impact, particularly through the use of sort of technology-based programs. Telemedicine has been, a great benefit to those, groups of people. So there is stuff on the horizon, and there is a silver lining to this. But, unfortunately, it's sort of not a challenge that we're necessarily going to solve overnight as well. It's going to take a very intentional approach.
Intentional approach, a thoughtful approach. I mean, these are pretty daunting issues. Thanks so much, Yusuf. And Christine, I'd like to hear from your perspective what you think the impact of this substance use acceleration has been through the pandemic.
Yeah, when we look at the data, we see that about 70% of people with a substance use disorder are actually in the workforce. Given the prolonged periods of stress and many of us working from home, we're seeing a large number of people, as Yusuf mentioned, turned to substances and particularly alcohol as a way to cope. We're still in the early stages of being able to quantify the impact of increased substance use over the past couple of years. Based on what we're seeing, though, we do expect that we're going to see more prevalence of substance use disorders, as well as more complex issues when presenting to care. Some of that is because of delayed care. During certain points of the pandemic, there was a lack of treatment facilities that were even open. So members were not able to even access care if they had the means to do so. Other communities, as Yusuf mentioned, there's just a shortage in general of accessible and affordable care, all of which are contributing to potentially delays in reaching out for support. Also, potentially more complex issues because of the comorbidity that accompanies substance use. It doesn't usually present alone. it presents in combination with a mental health diagnosis and or a physical health concern. So with all of those things in mind, we see that employers can support members by offering resources really throughout a continuum of treatment options. There's the need for resources from building awareness through education and prevention initiatives to providing early intervention access points, as well as treatment options for more acute and complex needs. And all of the while, ensuring that quality care is being provided to members as well.
Exactly. Thank you. I'd love to know from your perspectives each, perhaps, Yusuf, I'll start with you. What does this mean for payers?
Yeah, it's a great question, because I would say that for payers, being sort of health plans and employers both, this is a very real business issue. It's one that actually has a direct impact on their claims today. What we've seen as we work with over sort of 100 large employers, enterprise organizations, some of them numbering over 100,000 lives, within their population. They are really, really hard hit by these substance use disorders, not just from a cost perspective, but also sort of the impact this has on their workforce. So we've actually had more than one client recently mention that they've actually had cases where there's been overdoses on the site facilities. This is something that is really, affecting disability claims and, productivity and, absenteeism, presenteeism, and all sorts of those issues. But if we just look at healthcare cost alone, so what is the healthcare cost of people with a substance use disorder today? What we find is that typically untreated substance use disorder costs in the region of 4 to 5 times more than people with treated substance use disorder. So you're typically expecting to be paying anywhere between $25,000 and $30,000 in healthcare claims, excess healthcare claims for people with untreated substance use disorder. So if you then consider the fact that actually only 10% of people are in treatment, and you're paying significantly more for sort of untreated people, that itself is a real challenge. And then for the people who are in treatment, if they're in low quality treatment, what you often find is that that treatment naturally doesn't work because it isn't very evidence-based. And so they're going to be going through multiple rounds of treatment and often paying more than they need to be, from the outset, if they sort of accessed a high quality evidence-based practice in the first place. So increasingly, the partners that we work with, and it's across all different industries, whether it's construction, manufacturing, professional services, white collar jobs as well, financial services, etc. They are looking at offering a substance use disorder program for both alcohol use disorder and opioid use disorder as a way of reducing overall healthcare claims and saving money on medical claims. And I think that's the bottom line at the end of the day. Like, it is the right thing to do. It has an impact on productivity. It has all sorts of impact to the culture of an organization and making people feel, comfortable in sort of admitting that there might be a challenge that they're going through and feeling supported by their employer. But there's also a very real business case that actually corresponds to line items on medical claims cost savings, that can be made in the long run. So, we definitely see that as being an increasing factor. And it really comes down to the statistic that Christine shared just now, which is that 70% of people with a substance use disorder today are in the workforce. So they are people that, are around us. You might not necessarily know who they are, because it is an issue that's characterized by a lot of stigma. Often they're high functioning people for the time being, up until the situation gets really bad. And that's where you start to get those instances of, overdoses and just safety violations actually happening in the workplace because people might be under the influence. I think also in particular, as we look at, particularly for white collar jobs where we're starting to see more remote work become available, more hybrid, work as well. There's a real challenge in detecting some of these problems early on there.
And Yusuf, I'll add to that what we are also seeing payers do to address some of what you shared with the outcome, the financial outcome of lack of treatment, is they are looking at expanding their networks so that they can meet that increasing need for addiction treatment. And they're doing that by strategic partnerships with a variety of vendors, looking at point solutions and facilities of quality. Also looking at creative ideas such as virtual support and virtual peer support, and really virtual substance abuse resources to support intensive outpatient and outpatient treatment kind of came to life at the start of the pandemic. And we've seen them continue throughout, even once we've returned to in-person treatment.
And it's a great point as well, because, going back to that sort of, and it for me, it like always goes back to the first principles of how many people with these, issues are actually accessing care. You have that 10%. You don't move the needle substantially on that without really changing how you approach treatment and offering a virtual component to treatment. We have examples of employers that are in remote settings where just in-person isn't possible if they want to see, a provider within a reasonable amount of time. So I think we have seen a lot of openness over the past couple of years, and that started to pay dividends for some of the most forward-thinking employers who took early action.
Can I just ask you, there still seems to be this idea that addiction is solved with willpower, or perhaps it's even a moral failing. I'd love to just clear that up. I understand that I think you've got a different stance. Can you talk a little bit about why addiction is a chronic disease, in fact?
Yeah, absolutely. And I think this is, so definitely a common misunderstanding, but one that we're actually starting to see really shift, certainly within the medical community over the last couple of decades, and just more broadly, with people who now sort of understand behavioral health overall. So, the simple fact is that addiction is not a moral failing; it is actually a chronic condition. And with every chronic condition, how can I say that? There are certain sort of components that constitute a chronic condition, such as heart disease, hypertension, diabetes, mental health and substance use disorders as well, right? And they are that people don't choose to have any addiction any more than they choose to have heart disease in the first place. So, for instance, if you compare heart disease and substance use disorders, you find that actually there are genetic components to both of them. So there are multiple addiction genes that have been identified that help to predispose somebody to having a substance use disorder in the first place, in the same way that ethnicity and your genes actually play an important part as to whether you're at risk of cardiovascular disease. They're also an incredibly important environmental component. So we know that people in high stress situations, particularly those who have been surrounded by peers, whether it's family or friends who have abused substance before in the past, or who have witnessed some type of violence and might have post-traumatic stress disorder, they are more likely to actually use a substance use disorder, in the same way that we know that there are environmental causes such as stress, again, obesity and a sedentary lifestyle that actually lead to heart disease. And then really importantly, as with every chronic condition, it actually rewires your body chemistry. So what you find with substance use disorder is it starts to actually rewire your brain in a very reversible kind of way, but nonetheless, it has an impact on people's behavior. So executive function, for instance, are areas that are suppressed in the moments of greatest need, actually. And this is something that an individual with substance use disorder doesn't actually have a whole lot of control over, unless they're actually in treatment in the first place. And then finally, it has a relapse rate like every other chronic condition, albeit it actually has a relapse rate that can be lower than heart disease and diabetes, where it's incredibly difficult to reverse those conditions. It actually isn't as difficult to get a substance use disorder under control if you have access to holistic management. And I think that's what it really comes down to at the end of the day. If it's a chronic condition, sure, like that's challenging, but there are ways of managing a chronic condition. And it really comes down to holistic, whole person care, one that really understands where an individual is on the continuum of care, that is personalized to their specific level of need. Some people might need access to prescription medication. Some people might need access to counseling as well, in addition to that. And then you need to modify some of those social risk factors as well. So as with every chronic condition, it can be managed, but we should stop thinking about substance use disorder in terms of sort of a 4-week, treatment course, or a 6-week treatment course, or a 12-week treatment course, because the reality is it's something that lives with you for a very long time. So you need long-term care. It's not just about short-term success, it's about long-term outcomes.
Absolutely. And Christine, from your perspective, do you think employers, other payers, society accept that addiction is a chronic disease that can be treated?
think payers have started to recognize that, and that's related to some of the statistics, again, related to the business case that Yusuf shared and the interventions that they're taking to grow their networks and to offer a continuum of resources in different modalities. Employers overall, I think, are starting to recognize the need to address substance use disorder and treating addiction as a chronic disease. Some employers are really getting creative and innovating in this area by partnering with some of those carriers to build out networks for centers of excellence. Other employers are partnering directly with local institutions and point solutions, and again, adding those resources to support employees across the continuum. For society as a whole, I think we're making progress. We still have some work to do. There still is some stigma, as you mentioned, related to substance use and addictions because of that idea that it's just about willpower. However, we are seeing that stigma decrease over the past few years, and the more people are willing to come forward and to share their stories, the more we will see that stigma continue to be reduced.
Yes, I think that's super hopeful. And speaking of which, now I'd like to segue into how payers should approach substance use care.
I'm happy to answer, that, and I think like with sort of a question like that, we like to start at Quid Juniors from a first principles approach, right? Because there is a huge body of evidence that has been built over decades around what are the types of treatment that actually work most effectively. And when we talk about quality, which is a real issue over here as well, really comes down to actually ensuring that providers are adhering to evidence-based practices. But in particular, actually, there is real skin in the game. So I'm a true believer of value-based care. And there's an entire spectrum of value-based care, all the way from sort of clinical performance guarantees to more of a capitated risk model. But some component of value-based care is important. So if you sort of mix those ingredients of, first principles, we know that things like medication-assisted treatment, cognitive behavioral therapy are incredibly effective. So we should ensure that we are actually holding from a payer perspective, we are holding providers and vendors accountable to having very robust, clinically robust programs that actually follow those first principles. But in addition to that, there should be an important component of also holding them accountable to delivering actual outcomes. Because today it's easy to sort of whip up a great sort of great looking, engaging experience. And then look at the wrong markers in terms of, okay, how many people access treatment or how many people engage in treatment? What really matters is how many people sort of engage in treatment and then had good clinical outcomes based on a set of measures and scales that have been clinically validated in the first place. And then are we tying reimbursement to those clinical outcomes? And these are sort of issues that we think about a lot and, we believe are incredibly important. In addition as well, and Christine mentioned this a little bit earlier, you have an entire continuum of care, right? So, payers shouldn't be focused on programs that take a one-size-fits-all sort of cookie-cutter approach almost to treating people with addiction care, because the reality is some people, might require more of a preventative sort of program, whereas other people might be, more towards the moderate or severe end of the clinical criteria for a substance use disorder. Other people might require inpatient care followed by long-term relapse prevention. So ensuring that the program is really whole person and actually treats wherever an individual is on the continuum of care, again, becomes incredibly important because, those same approaches sort of don't necessarily scale well, on sort of different areas of that continuum. And then the final sort of challenge that we see, payers on both the health plan and employer side sort of facing today is that there are a lot of point solutions out there, but sometimes if they are very focused on a particular piece of the continuum, for instance, only prevention, or only long-term management, it actually makes the ecosystem incredibly confusing for an employer, for a health plan to figure out where does this slot in overall. Or if it's only single addiction focused, because we know that more than a third of people with a substance use disorder today might have multiple substance use disorder, and sometimes that number is even higher. You might have 70% of people who are smoking and using alcohol at the same time, and they're very codependent on alcohol and opioid use disorder, right? So if we're only treating one without the other, how do you expect to have super effective long-term outcomes? So I think these are all sort of fairly complex questions, and there's a lot that goes into what is a great program depending on the target population. But I'd say there's some of the things that payers need to be thinking about when evaluating partners.
These are really important considerations. And Christine, what are your thoughts on digital treatment for addiction? I know you mentioned that earlier, some of the benefits.
Yeah, so digital solutions really can be a great way to increase access to care. They have the ability to scale at a much faster rate than what we think of as a traditional kind of brick and mortar solution. And so helping to reduce barriers to care for people who live in rural areas or other areas without access to affordable treatment. Also seen offering benefit to people who work non-traditional hours, for whom it can be difficult to find a provider or a treatment facility that has programming based around their work schedule. And we're seeing them, what's neat is we're not seeing them used kind of in a standalone. We're seeing them integrated and used in conjunction with traditional treatment modalities so that they can provide ongoing skills training and reinforcement between sessions. So it's bringing the best of both together as well.
Thanks so much, Christine. I have so many more questions for both of you, and I can't believe we're already running out of time. So I'd like to ask, perhaps Yusuf, I'll go to you. For payers that are looking to offer some kind of integrated substance use care solution, as we've discussed today, what advice can you offer?
So I think integrated is probably the key piece over here. Going back to sort of one of the former points that we were discussing, you don't want a million different point solutions depending on the individual addiction or where people are on the continuum of care, or even whether they require virtual or in person. So actually having sort of a holistic and integrating care navigation process that involves a very clear assessment for individuals that are upfront, that ideally is based on some kind of evidence-based guidelines. So for instance, we use for our addiction care navigator product, the American Society for Addiction Medicine 6 dimensions of care, to understand exactly where somebody is on the continuum of addiction care, but also what other comorbidities potentially need to be in place. So that becomes super important. And then just ensuring that they can be diverted to sort of the best possible treatment program for them. Whether that's virtual, whether that's in person, depending on their assessment. So it's a very tailored, care plan that involves minimum trial and error, because this is a very sort of challenging group to engage, and you want to ensure that they're able to have the best chances of a great outcome from the get-go. So I think just the integrated piece, ensuring that sort of the partners and vendors are able to really offer that, whether it's multi-addiction, whether it's virtual or hybrid, and also just in terms of the individual providers who actually access it, offering choice in the counsellor that you're able to work with, based on what your own personal preferences are as well. One other final point I also wanted to add is that one of the things that we've seen over the last couple of years, and it's been a real silver lining, is as Christine and I mentioned, the availability of virtual care programs for employers and payers. Now, at the same time, there have also, particularly as we look at sort of the news today and the headline, there have been some bad actors when it comes to things like controlled substances or telehealth, where they've been over leveraged on sort of just making, for instance, medication accessible to people, but other products that maybe don't have the same sort of gross margin or financial profile as medications are sort of not as as sort of key a part of the overall care plan. So we're starting to see a bit of a reckoning of virtual care providers, and I think just ensuring that we sort of start with a member first approach and really understand, for an individual with a substance use disorder, what is most relevant to them, and how can we have the right sets of checks and balances in place to ensure that the treatment programs we have available are indeed, the best for that individual. And there is there is independence between sort of the vendors and the actual providers that are delivering care themselves. I think that becomes increasingly important. So, we are seeing the industry headed in that direction. It would be a shame to see, payers and employers maybe sort of take a pause in light of some of the challenges with, certain providers in this space. But I think asking those questions around clinical rigor, outcomes, and how you ensure provider independence as well, and you're really taking a holistic approach, is incredibly important.
Really great insights. Thank you so much for both of you sharing these important pieces of advice for our audience. And thank you for your time.